Well, dear friends, dear participants, dear delegates, thank you very much for joining our session. As Hugo already said, the Esge online meeting brings you the state of the art today. But we shouldn't forget that the future has already begun. And as some 40 years ago, we were trying to convince everybody not to do a laparotomy, but to start using minimal invasive surgery, we now have a new wave that is a little bit comparable to the cancer therapy right now. You see that in the cancer therapy, there is a very individualized concept right now with a tailored medical therapy and reducing the surgical point of view. For example, using sentinel lymphadenectomies. The next step should be, and this is, I think, reasonable, even further minimizing the surgical trauma. And this seems possible. We have a few good guys here who will help us through the session. There is Dr. Devassy, who is promoting the new technique that we will discuss in the Gulf region. We have Mr. Cranston, one of the pioneers working in the UK. And then we have the panelists, Friedrich Gill, Jordi Rodriguez, and Antoni Pesarodona. The presenters of the day are Hugo Verhoeven and Whye. Hugo Verhoeven is the chairman of our Esge working group, taking care of this new technique. And Whye is the key opinion leader in Asia. I would like to give the word and the floor to Hugo Verhoeven.
Rudy?
Yes.
Rudy, can you hear me? I think Professor Cranston, David Cranston, wanted to say also something. As the president of the International Society of Minimal Invasive and Virtual Surgery, do you allow that?
Of course. I thought he would continue introducing you.
No.
Well, thank you very much indeed. I have just given another seminar on William Osler, who was one of the founding fathers of Johns Hopkins, who said that diseases that harm require treatments that harm less. And I think we're going to hear a lot about that today. So I am a urologist, in fact, but also I am head of the high-intensity focused ultrasound unit in Oxford. So it is a great pleasure to join with you today as we think a little bit about high-intensity focused ultrasound as well as other things. So Professor Hugo Verhoeven, actually from Germany, is going to introduce that to us, and I'll pass over to him to start the seminar. Thank you very much, Hugo.
Okay. Rudy, shall Rajesh say something, or shall I start my presentation?
Well, I thought Rajesh...
I will speak after you do.
Yeah.
No, Rajesh, okay. First of all, well, shall I say, ladies and gentlemen, or better, I think, dear friends, thank you, of course, for allowing me to attend this lunch symposium. It's not only a great honor, but also a great pleasure. And it's a nice feeling, of course, to be surrounded by experts in the field of Hifu, like Professor Cranston, Professor Whye, and Professor Rudy de Wilde. So, Friedrich Gill has been from Vienna, has been my co-author since a long time, but apparently he's not joining us today. So, the topic of my presentation will be non-surgical ablative therapy for benign disease of the uterine wall. And as Rudy said, I'm at the moment the chairman of the ESG working group on non-surgical ablative therapy. So, disclosure, well, I have not that much to disclose, so I have nothing to disclose, but I would like to thank especially Peng from the Hifu company in Chongqing for his logistical support. Well, high-intensity focused ultrasound is not at all a new technology, but unfortunately, most of the gynecologists and even reproductive endocrinologists do not know this technique at all. On the other side, dermatologists, cosmetic surgeons, urologists know this technique very well. It is a non-invasive technology providing an alternative or a complement to surgery, radiation, medication, and cancer therapy. I didn't believe my eyes when I saw that more than 100 indications are known for Hifu and are under current investigation. And this is the list of all the indications for a Hifu treatment. And I think we are, as gynecologists, interested in the oncological indication and, of course, in the women's health indication. And you can see there that uterine fibroids, but also breast cancer, breast fibroadenomas, and then adenomyosis are main topics for this treatment. But I've been many times now to Chongqing. I saw that also bone metastasis, prostate cancer, hello, Professor Cranston, but also a pancreatic cancer, soft tissue cancer, bone cancer are treated by the Hifu technique. We will talk today, of course, only on fibroids and adenomyosis. Let me show you three pictures. About 1.5 years ago, I went to Chongqing, and there were two guys. In the middle, you have Professor Whye from Singapore, and next to him, Professor Felix Wong from Hong Kong, who tried to convince me to have a look at their new technique. And I said, yeah. So they said, come and have a look. And when I saw what they were presenting there, and I heard and also Professor Shilong Li from Taiwan, I said, what? That is maybe something I should have a look at. So less than a year later, we organized already in Vienna, together with Professor Friedrich Gill, a quite big symposium on Hifu, and you see with Professor Whye, but also with Professor Clense and Professor, where is she? Oh, there she is. And the people from Hifu, Chongqing. That was the beginning of our center that we are planning in Vienna. And hi, Rajesh. The next project will be that in Dubai, we would like to make a big center on Hifu, and out of Dubai, trying to invade the Middle East. And we met with Professor Rudy, with Professor Rajesh and myself in Dubai, and this was the starting of our project. So, what is ultrasound-guided Hifu ablation? And I show you a small video of 2 minutes, because this explains you more in 2 minutes as a 15 minutes talk.
An ultrasound beam can be brought to a tight focus at a distance from its source, with sufficient energy concentrated within the focus. The cells lying within will be killed without damaging the surrounding tissues. High-intensity focused ultrasound, Hifu, is, therefore, a non-invasive method of producing selective and trackless destruction of deeply seated tissue targets within the body without causing any damage to the overlying surrounding tissues. Ultrasound-guided Hifu involves Hifu ablation under the guidance of real-time ultrasound imaging, which can achieve an uninterrupted visualization of tissue coagulative necrosis during the treatment via grayscale changes in real time. The ablated lesions demonstrate an echogenicity or grayscale changes in the ultrasound images after the sonication, which enables immediate assessment of patient's response to ablation, ensuring a safer and more controllable therapy. Imaging fusion and three-dimension digital reconstruction function provide doctors with a much clearer vision during the whole procedure. Thus, doctors can finish the treatment with an ease. Ultrasound-guided Hifu, a new option for the gynecologist to manage uterine fibroids and other gynecological benign tumors, can maximally preserving the integrity of the uterus. No surgery, no bleeding, and no anesthesia. Patients can even chat with doctors during treatment to ease their tension. Patients can go home in nearly 2 hours after the treatment and resume normal life the second day after treatment. Post-operative MRI may still detect the presence of ablated lesions. However, vascularity is now absent in the ablated region, as the ablated lesions will gradually shrink or even disappear over time. The symptoms will also be gradually alleviated or eliminated.
Okay, this gives you, I think, a very nice introduction to the technique of Hifu. So the principles of Hifu, we should imagine that a transducer of Hifu therapeutic system converts electric energy into acoustic energy. So the ultrasound emitted by the transducer is focused onto the target tissue, and at this target focal region we reach a temperature of 65% or 65 degrees or more, and irreversible necrosis is induced. So as you can see on the diagram, Hifu ablation is performed under real-time monitoring by either ultrasound or MRI. Here once again we have on the left side the transducer who is producing ultrasound waves, and they are concentrated on the target tissue where heat of 65 to 100% is reached, and on the way between the transducer and the target tissue, the intensity of the energy is reduced so that on the way to the target tissue, the damage to the tissue is always getting less and less. This is, I think, a very important slide because I experienced the Hifu technique at the beginning as quite difficult. And not only at the beginning, but also going on with trying to treat the patients. I was always very happy that we had the telemedicine support center in Chongqing, where Peng and its assistants are 24 hours a day available for assistance. That means if Professor X in South Africa and I in Germany, we have problems, we can always have contact with Chongqing for support. And that is, I think, very important for all people who are interested in technique, that they know that there is always something behind them to help them. There are 3 systems available for Hifu ablation. It's the GE system, the Philips system, and of course the Chongqing Hifu US guided Hifu system. What are the advantages? As you can see here, we have the clinical advantages. That means no surgery, we have no incisions, we have a very short or no hospital stay at all. We have practically no risk of bleeding, no general anesthesia. There is no damage of the surrounding tissues. The patient is feeling not that much, so she's at minimal discomfort. And important for future pregnancy, it seems to be that the uterine function is mostly preserved. But we have also the social advantages. Practically no recovery time. Patients can go to work, exercise very quickly. We have an improved quality of life and lower costs. So, to the technique. I went to Chongqing and I tried to get there an initial information on Hifu. What is very important is that we are working in a very normal room. Not an OR, it is not an MRI room. We are working in a very normal room. On the left side, there is the patient laying on her belly. And on the other side, there are the doctor or the doctors who are doing the procedure. And there is a continuous hello? Yeah. There is a continuous communication between the patient who can tell us that she has pain in her legs or that she feels burning signs on her abdomen. And that is very important to change the technique. So once again, left side patient, right side, and in a normal, as you see, we have no masks. Now it would be different, of course. So if we want to understand Hifu, we shouldn't start to try to understand Hifu if we do not understand MRI, ultrasound, real-time ultrasound, if we have no idea of the anatomy, the pelvic anatomy, if we do not know how the Hifu techniques are working and how we should interpret the procedure. We are going to talk now quickly on Hifu for benign gynecological tumors, and we are going to concentrate on uterine fibroids and adenomyosis. Interesting is, I didn't know that there is a worldwide registry of 140,000 Hifu treatments for benign uterine cases, and the safety profile is established. If we take this image of the FIGO staging of uterine fibroids, you can see that practically all fibroids that required surgical intervention can benefit from Hifu. We were very proud about a year ago that the National Institute for Health and Care Excellence issued their guidelines for the treatment of uterine fibroids for the ultrasound-guided, high-intensity focused ultrasound for uterine fibroids. Because if those people are issuing guidelines, this is certainly a sign of recognition and is the beginning for a higher recognition of this technique all over the world. I just want to talk very shortly on these two studies. The first one is a prospective multi-center study where 2,400 patients were followed up, 1/3 with Hifu, 1/3 with myomectomy, and 1/3 of hysterectomy. And they were looking after 6 and 12 months for adverse reaction. And we have not too much time for that, but you will see that in the Hifu group, the major adverse events were three patients, 0.2%, and the major indication was skin burn. In the myomectomy group, we had much more major adverse events, especially bleeding, and also in the surgery group. And in the second paper I have here for you, this was a retrospective analysis of the adverse effects after FUS for uterine disease. We had 27,000 patients. And you can see here that about 20,000 of them were fibroids, 8,000 adenomyosis, and the other are a little bit out of this presentation. And here again, we see that skin burns were the major complication, but you see that this major but not fatal complication was only 0.3%, and all the other, like bowel injury and everything, 0.05%. What we can say that the complication rate is quite low. Let's have a look at ultrasound guided Hifu for uterine fibroids so that you can see this is the MRI image pre-treatment after contrast. You can see very clearly the fibroids. If we go down here, we have here again pre-treatment with contrasts. 1 day after the surgery, you see that the necrotic area has no more vascularity. 14 days after the surgery, it's getting smaller, 4.5 months, 10 months. So the literature tells us that the annual absorption rate is 67%. That means there is not a possibility that everything will completely disappear. Have a look here. Single fibroids, contrasts, vascularization, post-Hifu, multiple fibroids. And here you can see also very nicely. And from my friend Raymond Zaidson from Soweto, I got this image they have there in South Africa. Incredibly amounts of fibroids in young people. And instead of doing laparotomy, he's doing Hifu on this enormous uterus and probably with effects. No, I want to go. So, treatment techniques for fibroids, laparotomy, laparoscopy, or Hifu ablation. Difference is the scarring. Left, big scar. In the middle, laparoscopic scars. On the right side, no scars at all. This is the image of the uterus itself. Adenomyosis is the second most important indication. Adenomyosis is, as you know, a benign uterine disorder in which endometrial glands and stroma are pathologically demonstrated in the uterine myometrium. We have noted the definition and the diagnosis of adenomyosis is done by histology or by imaging techniques like transvaginal ultrasounds and magnetic resonance imaging. Let me show you this Hifu treatment of focal adenomyosis. On the left side, you see the pre-treatment T2 image of the adenomyosis. In the middle, the contrast-enhanced image. You see very nicely the perfusion of the adenomic lesion. And on the right side, we have the image post-treatment without contrast, and you see very clearly there is no perfusion. Diffuse adenomyosis, same thing. On the left side, diffuse adenomyosis, contrast, and this is the image post-treatment E1, and you can clearly see that about 80 to 90% of the adenomyosis is coagulated. I finish my presentation with one of my first trials. So you start with MRI and you see diffuse adenomyosis, as you can see here. Once again, normal room, no OR, and the machine and you are there without any special precautions. That we saw already. So MRI image. For me, the most difficult thing at the beginning was to visualize the myoma or the adenomyosis on ultrasound. On MRI, it's very easy. But on ultrasound, it was for me at the beginning a torture, and I was very happy to have fantastic people next to me. So as soon as you localize the myoma or the adenomyosis, from that moment, the computer is taking over and will make slices of your fibroid or your adenomyosis and start the coagulation. The complete procedure takes about, this was 70 minutes. As I said, we were sitting next to the patients after the procedure, looking always for skin burns. Patient is leaving the room after 1 or 2 hours. The same day she's going home, and this was the image 1 day later. So very nicely, the necrotic area. So we had here about 80% of the adenomyosis was coagulated.
Dear Hugo, your lecture is so interesting, but don't forget Whye Lee. He also wants to tell us something, so please come to an end.
Okay, before you go on criticizing me again, thank you very much for coming. And there is one more thing. At the end of the lecture, we will have the possibility to have an extra Zoom meeting for questions and answers on ultrasound-guided Hifu. Thank you very much, and I hope I was not too long. Thank you.
Dear Hugo, a perfect lecture, as always. Before we go to Whye Lee, I would like Dr. Rajesh Devassy to give a short intermediate. Dr. Rajesh, please.
Hugo, thank you for the wonderful lecture. Amazing points and insights on the Hifu. You know, when you told me probably 2 years ago in Shanghai about Hifu, and we met the team of Hifu, I was thinking, why do you need Hifu when I can operate them very successfully by laparoscopy? But then thinking about it, looking into all the success stories, what Hifu is doing, we started thinking, why operate when you can alleviate the women of the problems without the surgery? And we are here as ESG group to establish a panoptic way of treatment, minimal or non-invasive method of treatment. And adding adenomyosis to Hifu has become a real bonus of indication using I have one question for you. What about the possibility of leiomyosarcoma in patients who are unsuspectedly having this lesion in one of these large fibroids that are being treated with?
Yeah. Shall we answer that question at the end of the meeting of Professor Whye Lee? Because he has much more experience in that. That is the question that has been asked to me every time when I have a lecture. And of course, you know, leiomyosarcoma after morcellation is a hot topic. Well, also here, but you are coagulating everything. a leiomyosarcoma will also probably be coagulated. And I heard from the experts in Chongqing that there are no cases reported of, because you have no material, you have no tissue. Yeah? So I think if you're coagulating at the heat of 80 degrees, also a leiomyosarcoma will probably be coagulated. But this is a very premature answer.
But this was a very clear answer, and I would now suggest that Professor Cranston introduces Whye.
Thank you. Thank you very much indeed. Well, it is, as I say, it is a great pleasure to be part of this group, even though I'm not a gynecologist. But it's a great pleasure to introduce Professor Whye from Singapore, who has a lot of experience and is going to be talking about Hifu being a good addition to gynecological surgery, and indeed not only gynecological surgery, but many other aspects of surgery. And I really look forward to hearing from him. So, Professor Whye, please take the floor and give us your benefit of your wisdom. Thank you very much.
To one side. First and foremost, can you all hear me?
Yes, we can hear you.
Okay, sure. Okay. Thank you so much for the invitation. The topic given to me was, why is Hifu a novel supplement? Initially, I thought of using the word complement, but it was changed to supplement. But you decide after the end of my talk whether it's a supplement or a complement. And I'm glad that somebody actually has the title for this session as treatment of symptomatic myomata without medication or surgery, a rising phoenix. Indeed, it is a rising phoenix. A walk down memory lane. You know, when you meet Hugo after 10 years, he was very much of a presence in Southeast Asia and Asia, and then he disappeared for a while, and then he came back. And you know, Hugo, he even wants to teach me how to do laparoscopy on Alaskan crab. And very important, this I kept it in every presentation I presented, because it was in Chongqing in 2019 where David Cranston, the president of ISMIVS and president of APAGE, which I'm fondly attached to with Professor Lee Chilung, whereby we signed the MOU with regards to training, education, research, and certification. We need that because Hifu is not meant for everybody who wants to behave like a cowboy. Okay, you are mostly in Europe and some of us in Asia, but I'm here, right down here in Singapore, and the time now is about 10:10 p.m. at night. So good morning for those of you who are still in the western side, and good afternoon, Middle East side, and actually good evening for those who are in this part of the world. Just a summary, for adenomyosis and fibroid, it's actually simplified laparotomy. When I was taught as a junior doctor, laparoscopy, as I was growing up in my 30s and 40s, and then transvaginal, whether it's hysteroscopic and very popular, V nodes, because yesterday I tuned into the V nodes lecture, was very interesting. Again, the basics of surgery for fibroids and the worries, the basic risk is always hemorrhage and needing to convert to hysterectomy, especially when you have a patient who's looking forward to just a myomectomy, and to wake up and tell that patient is converted to hysterectomy, that is a shock to them. And of course, after that, we are worried about abdominal adhesions. And when they're pregnant, we are worried about scar rupture. These are the three main worries. And of course, undiagnosed risk of leiomyosarcoma. Maybe I touch upon leiomyosarcoma here. Rajesh asked a question, what do you do if you have a leiomyosarcoma? Well, what do you do when you have, for the past 10, 20 years, advising patients to watch, observe the fibroid? That is because in your mind, in all honesty, you think, you're very confident what you're asking the patient to watch is a benign fibroid. And and the risk of leiomyosarcoma is probably less than 0.5% in the range of 0.3%. In my career, 30 years doing laparoscopy and laparotomy, I have seen only 3 cases of leiomyosarcoma that came back to me in the histological specimen. But again, this is right. I will touch on this again. I think this risk, especially now, is a self-inflicted injury by doctors, especially gynecologists. Now, women of today, they are educated, independent, late marriage, elderly mothers, single, in waiting for the right man. Once you have this concept in mind, you will move on to the reason why we do not want to turn the uterus into a uterine Frankenstein. Okay, I know a lot of you are very great surgeons because all of you are from the MIS group, but again, probably the world has moved, concepts have moved, and woman power has come in. Other treatment will be drugs, ulipistol acetate, uterine artery embolization, which is still in vogue. And of course, what we always say, observe for the growth of the fibroid, especially when it's asymptomatic. This is really my personal journey, an evolution from laparotomy, open surgery, to laparoscopy, to really, truly scarless surgery. So Singapore B nodes is not scarless. They are invisible scars or hidden scars. This is truly scarless surgery. Hifu is sound, and sound wave has no radiation. It is just focused heat to destroy or ablate tissues. I want to remind everybody again that the very important 2 things to remember. One is you must create heat above 65 degrees to 100 degrees in order to be able to achieve decent ablation or destruction of adenomyoma or adenomyosis. Second, it must be real time. And when I say real time, it's really real time. For those of you who are doing obstetrics, when you see the baby move, that is real time. So today we are talking about Hifu, and we are touching on benign gynecology. I know a lot of you out there are great oncology surgeons that dissects everything within the pelvic cavity to lymph nodes and so on and so forth. But today we are talking about benign gynecology. And this is the concept of the virtual knife. The knife comes from this basin and extends to a point which is about 12 millimeters above the base here. It's invisible, it's a virtual knife, and it's a bloodless knife. Now, I took this picture when I was in Chongqing. It looks, note, the only burn you get is here at the point. You can move your hands across. Nothing will happen to you. Okay, look at the number of hands. So the burn is at the tip of the knife. Okay, I think Hugo showed this picture before, but just out of interest, when you do Hifu, it is actually burning little cylindrical structures like this. And if you want to know more, if you play football, it's like 3-3-5 formation. 3 by 3 by 5 mm. Okay, that's easy to remember. I think you have seen this, but and this is the real, not animated, this is a real picture of the patient walking in. I'm not going to show you more, but I will move on to very important. Patient is conscious, and the doctor is talking to you, checking on the patient. How are you? Do you have any pain? And do you have any discomfort anywhere? Now, one of the safety features is because you are able to talk to the patient, to communicate with the patient, and the patient tells you straight away whether there's any discomfort or shooting pain down the legs. And what is not shown here in the preparation is, before the Hifu is done, a lot will be done to the patient in counseling on the diet, how to degas the abdomen, shaving, and actually, although it's not a major surgery, we still advise patients to be new by mouth for at least 6 to 8 hours. reason is we do not want the bowel to be in the way. Okay, we move on to the next. So be careful, there are two different versions of Hifu. That is the MRI guided Hifu, and that is ultrasound guided Hifu. And we are, as gynecologists, we are only interested in the ultrasound guided Hifu. The real difference is in the ultrasound guided Hifu, you are able to have a non-perfused volume because you are able to treat with a higher degree of burn or ablation, and you are able to achieve something that's above 70% non-perfused volume. Anything below that, like in MRI guided Hifu and some other versions of the ultrasound Hifu, you can't achieve that. But what caught my eye is this. When I was told ultrasound guided Hifu is for the gynecologist or any trained doctor. So that started my personal chain reaction to learn. Yes, Hugo showed this. There's the MRI guided Hifu, which you send the patient into the tunnel here. And you know, when you send something in the tunnel, you ask the patient not to move. Yes, the patient will not move. But you cannot keep the bowel steady, okay? And you are not communicating with the patient. Whereas in the ultrasound guided Hifu, the patient is exposed in open. You are able to communicate, and all the gadgets here, the table can be tilted left, right, up and down. So the angulation, the flexibility is there. And just a reminder, MRI guided Hifu is not real time, okay? It is touted as real time, but it's not real time. Why? Because you have to subject the patient to 12 to 30 seconds of sonication, believing the patient doesn't move and the bowel doesn't move, and 45 to 90 seconds of cooling. So when you're firing, you do not see what lies in front or at the sides of the fibroid. You really are blind. There are lots of research and scientific papers, but it is always ignored by the English-speaking medical institutions, and I am guilty as one of them because I thought, there's no English written journal, who's going to believe? So I was one of them. And you have actually quite a lot of paper written on this. Now, I've always asked, why did it take so long to be accepted? You know, and I sort of summarize it in a simple message: is pride, prejudice, and maybe just ignorance. Pride, because how can anything from Asia be good? You know, it's still a developing or a third world country. And where is this machine from? From China, or the worst, because then it's the prejudice. You know, anything from China doesn't hold water for many, many years. Ignorance, just like me, I couldn't believe that they can produce something. So I'm also somebody who was in disbelief. I must thank the group of David Cranston, who actually helped for NICE, National Institute for Health and Care Excellence, to accept ultrasound guided Hifu as a modality for the treatment of uterine fibroids. Even then, just last month, and in fact last year, I have to write to some overseas insurance companies to tell them that ultrasound guided Hifu is acceptable and it's not research or experimental. So even the medical board of some insurance companies take it as still experimental and still undergoing research. Last count, there are already 151 or more users of ultrasound guided Hifu, compared to about only 4,000 plus by the MRI guided Hifu companies. Well, just to let you know, I got this message this week that Suning Hospital in China, and there are hundreds of them in China, December 2020 is celebrating its 10th anniversary of Hifu with over 9,000 cases done. So quietly, they have been doing more than 10 years ago, and many of us really do not realize that. I just took a picture from here. Do you know where this is going to? This has just been shipped and gone to my friend in Nigeria, our friends in Nigeria. And there's another one to be shipped up soon to Mexico. So while we were thinking whether this machine works or doesn't work, lo and behold, the developing countries or the third world countries are already accepting it, and we are still stretching our head to trying to convince ourselves whether it works or it doesn't work. Now, I've always quoted this paper because it's one of the early papers from the Chongqing Medical University, 757 patients. But I also realized something that in the initial collection of data, they probably collect fibroids, which is about 5 to 6 centimeters. Okay, so they have a very good success rate of 84% NPV, and they will show you when you go to Chongqing that the shrinkage is very good. You know, for example, at 3 months you get a shrinkage of about 30%, 6 months about 50%. So again, these are selected cases, well-chosen cases. So when you are embarking from Hifu, I think Hugo has a better figure to advise patients. I think it's about 76% after a year and not as high as 82 and 89%. I'll explain why, because these are chosen cases. Now, we always talk about the speed in which the fibroid shrinks. We actually never thought about at least you stop the fibroid from growing. And now, when I see my patient, the patient will ask me the same question: how fast does it shrink? But I will tell the patient, well, at least I try to help you and your fibroids from growing in you, so that you may not need to end up with a hysterectomy, or so that you do not have to bleed so much or lose blood. But whether the fibroid shrinks fast or slow really depends on your biology, your resorption capacity of your body. There are complication rates. There are no such thing as no complication rates. Even if I give you a nail cutter to cut your nails, you're going to cut your own nail one day. So there are complication rates, but it's very low. How low? This is one paper I think everybody should take a picture. It's 27,000 patients. Came out, published in 2018. And this is a paper Hugo was alluding to about skin burns, about 0.1%. Frankly, you will be taught how to avoid this. In fact, your trainers are very careful to tell you not to do certain things and to avoid skin burns. I'll talk to you later. But I want to talk to you about bowel injury, because that's what all laparoscopic surgeons, like a lot of us, are worried about. Unfortunately, we can't talk about vascular injury because Hifu doesn't really go into the rest, except for one case I know that was done by MRI-guided Hifu. Now, bowel injury is 0.01%. And this is what I advise patients for the past 30 years when I first started doing laparoscopy. It's about 0.4% or 0.3%. So it's already about 4 times less. Laparotomy, about 8 times less. Vagina, about 7 times less. So the injury to intra-abdominal organs is much less. Now, if you talk about skin burns, we get more skin burns lying in the sun in Bali Beach and wearing a pair of new shoes than using the ultrasound-guided Hifu. Many of us are asking me, what about does Hifu affect the antimullerian function or ovarian function? You are shooting energy to the fibroid, not even to the whole uterus. So it does not really disturb your ovarian reserve, like if you're going for uterine artery embolization. So rest assured that Hifu is neutral to the ovaries. Another commonly asked questions: will it have all the problems of scar injury, rupture, and all this in after Hifu for pregnancy? The answer here is Hifu treatment can effectively treat patients with uterine fibroids who wish to have children. It could significantly reduce the preparation period for pregnancy, it improves fertility, and so far, there's no abnormality in childbearing or obstetric risk. I love conclusions like this. I usually shudder at a conclusion that says we need more studies. Very proud of my colleague, Dr. Hong, went with me to Chongqing in 2018, and she used Hifu to treat one patient, and said the patient delivered a healthy, bouncy baby earlier this year. And I would like to show the first case when the machine was assembled in Singapore. I'm very proud of this video because it's my first case. Look at this. When you hit it right, and you see almost like snow falling, the ecstasy is immense. I always said it's like scoring the first goal when you're playing football, or holding a girl's hand for the first time. It's just immense, the pressure. This is my first case. Okay, let's move on. That's the patient. After I've done the Hifu for her on a Monday, she sent me this picture of her doing rock climbing on a Wednesday. And I warned her, please, this is a new technology in Singapore. Please go home and just rest, read a book. 5 months later, same patient gave me this picture, skiing in Europe. And this is her MRI. She was having anemia, bleeding, and she found a fibroid, which is about 4.8 to 3.7 centimeters. After treatment, it shrank to about 3.8 to 30.7, and it's still shrinking. I just saw her recently, it's still shrinking. And now we move on to what I call experience-based medicine. So let's leave evidence-based medicine behind and be ourselves. Many of us who are laparoscopic surgeons, we ask ourselves, if can treat or cannot treat the fibroid. It can be treated, how do we treat? I know this lovely classification, but to many of us, when we try to explain to patients, it's very confusing. It's only good when we explain to medical students and ask them for teach them for answers before exam. But really, I think this would be easier for us doing Hifu. Just 3 simple classification: submucous, intramural, or something pedunculated. Why pedunculated is always excluded? Because you can have a cord or loop of bowels around it, like if you do obstetrics, it's like cord round neck, a baby's neck. Or if you hit it, this will drop off, and you get a parasitic fibroid wandering in the abdominal cavity. I don't think the patient likes it. So I do not pick on pedunculated fibroids. I'll do intramural. May or may not do submucous fibroids with Hifu. Reason is as follows. This is a 41-year-old patient of mine. After prehysteroscopy, July 2019, I treated her intramural fibroids. This is a hysteroscopy picture. I don't see anything submucous. Maybe just a hint of something on the roof, but it is not submucous. 9 months later, it presents into the cavity like this one. That means intramural presenting a submucus coming down. 9 months later, and then 2 months later, I went in with the resectoscope and took out that submucous fibroid, which was originally intramural. And this is another patient, a nurse. I did Hifu for her for 4 centimeter intramural fibroids. I'm sorry, I don't have MRI pictures because it costs a lot for a nurse to pay for MRI. So I did what I know best, abdominal ultrasound. Why abdominal ultrasound? Because it's easy to explain to ladies, especially those who have delivered babies before, that, from the top is a bladder, and then this is your fibroid. After 5 months, and then she came back to see me just a few days ago, and it's all clear. And this is what she showed me, on and off. The fibroid pieces on the napkin, and she's a nurse. Now, selection cases is very important. More important is the management of expectations. This is a 32-year-old young lady, not married. When you see something like this on MRI, a fibroid which is darker color, and behind it something grayish, more whites. Now, we call this hypointense, and this is hyperintense because it's more grayish, whiter shape. Now, I have to tell her this will respond better than this. So that after 6 months to 9 months or 1 year later, if this is still around, it's because the texture of the fibroid and the vascular supply of the fibroid is different. Okay? Another patient, this is a single mother, also 31 years old with one child, complained of heavy periods. This is what a fibroid looks like. This is what she looks like. After about a year, I just saw her again. This is still slowly melting after a year. But look, this has grown. This was here, and this has grown. Why is this has grown? Because when I was doing it, I was trying to avoid bowel. So you have to learn how to avoid bowel and not to deliver too much heat and energy. These are my early days. So even now, I would not venture to do anything that is very near bowel. Again, I do not want to turn the uterus into a Frankenstein. Okay, I'm halfway through. Will Hifu replace minimally invasive surgery? Answer is no, but you will get a lot more patients with fibroids who will come to you for a second and third opinion. So we have to be very careful because these are patients from our colleagues. Back to that young lady. So look here, I just enhanced it a bit. The other small fibroids, which is not in focus here, are beginning to be extruded. In other words, they are becoming submucous in nature. Okay, they are being extruded, and this is what I saw when I did the hysteroscopy for her on the 11th of November, just last month. All these are the fibroids waiting to be born. So we have to tell them that Hifu doesn't melt everything, doesn't dissolve everything. Sometimes they are passed out, and we have to go in again to remove them with the resectoscope. And that's why I said Hifu and MR surgery will be complementary. It doesn't supplement it. It's a very interesting case. 48 years old, complained of swollen legs from walking and standing. She went to the nephrologist, the kidney surgeons. The doctor says normal. Went to the cardiologist. She hasn't got a heart failure. She came to see me, and you see this big fibroid caught between the cervix and the sacrum and the rectum behind. I turned her down because I know if I'm going to shoot Hifu so near to the rectum, I may burn a bowel. So I did what I know. This is the fibroid lodged deep inside the pouch of Douglas. You can see the engorged veins. The bowel is here, and I lift it up. You can see the big fibroid extending from right to left. And I did a myomectomy, and after stitching, you can see actually the engorgement is virtually gone, and she's well now. No more swelling of the leg. So there are cases I turned down. This is another case I turned down. Please remind me if I've taken too much time. This is the uterus, and you have to be careful. This is a fibroid. This is not the fibroid. This is not the fibroid. All these are bowel. So when you do an MRI, and that's why it's important for them to be fasted before MRI, because otherwise you see loops of bowel pretending to be fibroids. This is the fibroid. And this is what I saw when I did I turned her down and I did the laparoscopic myomectomy, and you look, it can actually flop. You lift it up, it drops. So, and you look at the base, although it's not so pedunculated like a thread in the balloon, but I turned it down because if I may shoot all the bowels around it. Well, when you start picking up Hifu, you learn a lot of new skills, like you use the color Doppler and you sort of know where the fibroid is. It outlines for you, not so good compared to MRI, but it does give you an indication where the fibroid is sitting. Then you know how to judge what is a good bladder for you to move the bowel away. So if you have a bladder that's filled up and it extends like a Batman, this is good because when you shoot, the sound wave doesn't cut into bowel. So this is a good case to do. So when you shoot, it avoids the bowel. Okay. Now you also learn if you have a shape of a bladder like a dome shape, it's not good because when you shoot, you're going to hit bowel. But as you move superiorly to the top of the uterus or the fibroid, you're going to hit bowel. So these sort of cases, when you have dome shape, you ask the patient to train the bladder again, and the trainers, the teachers will teach you how to do that. There are many tricks of doing it. See, I can't push the bowel away with a distended bladder, and this is the Foley scatter. When I cannot push it away, I know if I shoot, I'm going to hit the bowel. So these are things when you're unable to push the bowel away, don't shoot, and turn the patient down, go home, train your bladder again, and come back 2 weeks later. Another patient I turned down because she just had laser burns on the skin for her pigmentation. So this is what we learn. You, especially from the start, you have to be very careful. You cannot be a cowboy and say, "Oh, never mind." So I turned her down. What's interesting is this case. I look at it. I was a bit, I must say, too cocky, when they say, "Oh, just a scar, cesarean section scar, and some scars here, no worries," So I said, "Yo, I will do the Hifu for you." Then, to my embarrassment, I saw the scar, and you just look. It casts a sound shadow so huge that I'm not able to see the rest of the target organ, the rest of the fibroid. I move it to one side, and I know if I shoot, I'm going to hit the bowel. So again, this is a bit of cockiness on my part when I say, "No problem, I'll do it," but, Then I found out what happens is, taking a history is very important. I failed to notice there's a scar here, and what happens was she has another tumor, a desmoid tumor of the rectus. And after doing that, the surgeon actually put a mesh across. Okay?
Rudy, I wonder if we could, Rudy, I'm sorry to interrupt you. I wonder if we could ask you just to slowly come to an end so that we have some time for questions and answers.
Okay, sure. Okay, I'm not going to show you all these videos because I'll teach you about sleeping, hiccups, pain, bladder bubbles, grayscale changes. And I think Hifu is revolutionary. You won't need all this. And it avoids this morcellation headache among laparoscopic surgeons because sometimes we really do not know ourselves. How can you, after taking out a fibroid, put it in a bag? You really upstage it when you cut into the uterus, and you put it in the bag, thinking that you have downstage it. I think it's like what my friend says. It's like wearing a condom after sex. I think we're kidding ourselves. So we have to be very sure that if you're not sure whether the fibroid is going to be a leiomyosarcoma, if you have any doubt, please open up the case. So if you want to do a laparoscopy, true to yourself, honest to the patient, do it the usual way. Okay, all this anti-aging products, GnRH, all this MRI will be increased. All this will be a competition through clear, because myosure, radio frequency, uterine artery umbilical, all this will be your competitors, and you need less major operating theaters. You need less anesthetists. You probably have one anesthetist in charge of 4 anesthetic nurses. And what is important is you want to be a Hifu gynecologist, you have to be good at spatial orientation. In other words, if you still need a GPS to go home every day and something is wrong with you, you have to be good at pelvic ultrasound, interpretation of MRI, must have patience, abide by safety guidelines, and discipline, discipline, and discipline. And when you have a machine, you wish, you just have to see the solitary fibroid, 5 to 7 cm, and go home for lunch after an hour. You'll be surprised. You'll be filled with all this waiting to see you. Ladies with multiple fibroids, fibroids above the umbilicus, recurrent fibroids, patient who refuse surgery or fear of pain, single woman who want to preserve fertility, older woman who preserve the femininity, especially because of culture, tradition, belief. And I know certain Middle Eastern countries believe that nothing from the body should live, or no organs from the body should leave their body when they die. Women who came complaining to you about their previous gynecologists who asked them to observe the fibroids only to be offered a hysterectomy. And of course, women who has consulted their girlfriends, Miss Busybody, Dr. Google, Dr. Facebook, and women who knows everything better than you will come to see you. Now, my last picture, this is my opinion. Hifu is not arcade games, not a bowl of water with ultrasound. It is acquiring a smart virtual therapeutic system that comes with research, teaching, learning, and management. It is a whole new world of surgery that demands your undivided attention. And for the preservation of feminine and fertility, think about Hifu. My last picture, Marco Polo from Europe went to China in an exchange of knowledge, gifts, and learn from each other. I think we should do that again. And this also reminds me, if you travel through landmass or the uterine muscle, it is called adenomyosis. If you travel by a different route, the C route is called endometriosis. So let's make things simple in gynecology. And Hifu welcomes more Marco Polos, for medicine has no borders. Only politicians create borders for the world. Doctors should be borderless and unite the world. Okay, for those of you who are interested to know more about Hifu, I have designed 4 webinars. You can click on this and you find it on YouTube. Everyone has a specialist on Hifu. This is Dr. Choi from Korea, Dr. Chang, Professor Chang from Chongqing, and this is from South Africa, Dr. Raymond. And the last and not least, I think it's very important for you to, if you want to know more about adenomyosis and Hifu, tune in. This is good friend, Professor Eisingzi from Shanghai. Don't just take a picture of this, please include my picture. And I'm Dr. Lee from Singapore ONG Group. Thank you so much for your attention.
Thank you very much indeed. And that was very helpful and thorough. And I'd just like to add that you're not the only people who are having trouble getting the insurance companies to pay, because still in the UK we're having trouble with the insurance companies paying for this. But I think we're going to try and work through the patient user group as well, the fibroid users group.
Sure.
So let me pass over to Rudy to continue.
Do you want me to answer the insurance question? Do you want me to answer the insurance question?
Only one short answer, Whye, so we can close.
Yes. Okay. Most of the big insurance companies are AIA, Aviva, Great Eastern, you name it. The difficult insurance companies are those from really, one of them is Aetna, and a few of them from the European companies. I have to explain to them that this is therapeutic Hifu and not aesthetic Hifu, and this is acceptable treatment and not experimental. Okay.
Thank you for this very short statement. So our session comes to an end. It's a pity that we don't have more time for questions and answers, but there is a scan that will be produced in a few seconds, and you can scan it, and then we will get another session in near future to answer all your questions, and it will be the same group of people who took care of you today who will continue and give all the responses you want. So out of my point of view, the last word coming from Hugo to close the session finally.
Okay, thank you very much, Whye, David, Rajesh, and of course Rudy. I think this was a very interesting introduction to Hifu for the people who didn't hear about this technique at all. So we tried, Whye and me, tried to give a elementary introduction that nobody falls into sleep because we went into too much details. We want to give practical information so that the people say, no, I need to go on Google or whatever to find out more. I got now about 20 chats, questions. Of course, it's always the same. Where is Hifu available in the UK? Where in Germany? In India? In Singapore? So people are interested, but they just want to know where is it available. And I'm very thankful to Rudy and the Esge, the complete working group, to have had the chance to introduce the technique to a broader audience in the world. Thank you very much and have a good evening.
Thank you. Good night.